Hey everybody, Jim Ziegler here. A few years ago, I was on a trip to Baltimore with my girlfriend at the time. We were in the Inner Harbor, which is kind of a touristy spot, had just gotten some crab cakes at the Lexington Market, and we were exploring some of the sights. It was about 11 in the morning, and we came upon a guy lying down on a bench who was just passed out, not moving. We walked a little closer to see if he was breathing. It was a little surreal. He was middle-aged and looked homeless, dirty clothes, unkempt beard, and tourists were just walking around him. Half a dozen people walked around the bench as we got closer, nobody paying him any attention at all. As we got closer, it really didn't seem like he was breathing. I wanted to go over to at least shake him to see if he'd wake up, but I got no response. I felt for a pulse, and by this time, one of the workers in the dock came by to see what was going on. My girlfriend told the man that we were concerned, and I remember asking him to call 911. All the while, tourists, businessmen, and all kinds of people continued to walk around us, like river water passing around a rock. We didn't even get in their way, and nobody was going to stop to help. I thought situations like this in the real world were unusual to come by, finding somebody unresponsive and kind of clueless as to what I should do when there are no resources around. Then I was at a neurology conference in Boston last spring, and I took a break to work at a coffee shop when I found another guy unresponsive in the bathroom. By this time, I was a senior resident, and I felt a little more confident in dealing with the situation, but I really couldn't believe it. The thing is, it's not that uncommon in the medical world to find somebody unconscious or minimally responsive. Think of all the people who syncopize or seize. They overdose on opiates more and more these days, or they have heart attacks or strokes. So many different things can go wrong, and if you're the only one around, what can you do about it? The unconscious patient. We're going to talk all about this today on the Brainwaves podcast, because maybe one day you might see this too.
This episode was brought to you in part by Audible, your source for audiobooks. With nearly 200,000 titles to choose from at the click of a button, Audible makes it easy to find time to catch up on stories. If you like this episode so far, then we know you will like The Man Who Mistook His Wife for a Hat and Other Clinical Tales by Oliver Sacks. You can get this audiobook and others like it for a free 30-day trial at audibletrial.com/brainwaves. That's audibletrial.com/brainwaves.
This week, I'm joined by Dr. Ramani Balu.
I am an assistant professor of neurology at the University of Pennsylvania, and my specialty focus is in neurocritical care.
He previously joined me on the show in 2016 to discuss autoimmune and paraneoplastic limbic encephalitis. Thanks again for coming back to talk with me about today's topic, Ram.
Thanks for having me back.
So, Ram, let's get right into it. We're going to be talking about the management of an acutely unconscious patient. Unfortunately, there's way too much to review when it comes to evaluating an unresponsive patient, and usually in the hospital when you see this, there are a ton of people to help you out. Somebody's out there grabbing labs, keeping a finger on the pulse, reviewing the patient's medical chart, getting an EKG, etc., etc., etc. So in order to keep today's episode short, we're only going to focus on the first 5 minutes. And to make the situation a little more interesting, we'll pretend this is all happening on an airplane.
Good afternoon, this is your captain speaking with just a little flight information coming up on
The flight attendant calls out for a doctor overhead. Is there a doctor on board?
Sir? Excuse me, sir. I'm sorry I have to wake you. You a doctor?
To which you say yes.
That's right.
And you rush over to seat 19F to a middle-aged woman who's all of a sudden unconscious. Ram, what is the first thing that you're going to do?
Jim, I think the first thing you would do in this situation is the same as what you would do in any situation where you're faced with an unconscious patient. And I think that basically involves quickly assessing the situation and looking for the ABCs. So does this patient have a patent airway? Are they breathing? And do they have an intact circulation? The caveat would be that in an airplane, you're really not going to be able to do much in terms of securing an airway. And I think it's also important to realize that you don't really have people to call to do things like establish an airway with an endotracheal tube.
Not that that would matter, because airplanes come with the most limited supplies for artificially ventilating a patient. You'll see this becomes a theme here in a minute.
those types of devices for intubating patients, I think, are largely not available in whatever medical equipment that you might have in an airplane. But the basics are the same. So I would approach this patient and, number one, make sure that that patient is breathing, and number two, check for a pulse. And if the patient was not breathing or did not have a pulse, I would immediately start down the basic life support and then maybe the advanced cardiac life support pathway of starting CPR and trying to do things to get a perfusing rhythm back.
I'll interject here by reminding the audience that ACLS and ENLS, or Emergency Neurologic Life Support, algorithms recommend immediate chest compressions in a patient who's acutely unresponsive without a pulse, and if it's available, defibrillation when there's a shockable rhythm, like VFib or VTAC arrest. So placing chest pads on the patient as soon as possible, if they're not waking up, should be one of your top priorities after the ABCs. And all U.S. commercial aircrafts are required to have a defibrillator.
You know, a couple of other things that just kind of come to mind are how to position yourself in the situation where you don't actually have a table or a big open space to place a patient. So if this patient was in seat 19F and we're talking about the usual kind of 30 or 33 row airplane, there's not really a good space to bring the patient to a place where you can actually do any kind of good resuscitation. It's probably unfeasible to move the patient all the way back to the back of the plane or to the very front of the plane. So it presents some interesting challenges as to how you might need to do all of this care. Probably what I would do is in some way try to move the patient to the aisle where there are no seats so that the patient can be lying down. And then, if the patient is really pulseless, trying to determine a position where you or someone else on the team can give effective CPR is not a simple thing. The other thing I will say is that you're not the only medical professional that's there.
That is true. According to recent data, almost 3/4 of flights have at least one medical professional among the passengers. The majority are doctors, at least one of which is on 50% of all commercial flights. 20% of flights have at least one nurse, 4% have paramedics, and 4% have another medical professional. So not only is there a good chance that you're not alone in the air, the captain can also establish a direct line of communication with an on-call physician from the ground.
Contact the flight deck, get them to page StatMD and page for medical assistance.
One of the most valuable resources the flight crews have at their disposal is a service called StatMD. StatMD is a ground-based support center that provides medical consultations for in-flight emergencies. These are specially trained physicians who can help the crew make assessments and also give recommendations on how to treat the patients.
So Ram, back to your patient, the middle-aged woman who passed out in 19F. Once you've checked your ABCs, what are your next steps?
I think the two basic principles are to try and make sure that I am continuously doing whatever I can to make sure the patient is stabilized, and at the same time, try and figure out as best as I can what the problems are. And so in my mind, what I want to try and establish is whether or not the problem is due to some kind of structural brain injury. So I would be thinking like a stroke or an intracerebral hemorrhage, or is the problem due to some kind of global issue like a toxic metabolic encephalopathy, like is this patient hypoglycemic? Are they hypoxic? Or do they have some other reason for being unconscious, like did they have a seizure and it just wasn't noticed while they were on the plane? So I think what I would start doing is quickly first trying to gather a set of vitals. And then,
and there's a stethoscope and a blood pressure cuff and standard in-flight emergency medical kits, but no pulse oximeter. So you'll have to determine oxygenation based on your good old-fashioned physical exam.
Would be to look at their physical exam and see if they're cyanotic.
Are their fingers and lips blue? Is their skin pale?
And then the last thing would be to see if there is a glucometer available. And if there isn't, to give them empirically some dextrose-containing solution.
These would be some of the immediate steps you could take in a patient who's suddenly unconscious on an airplane at 35,000 feet. Vitals, checking for a heart rhythm, administering dextrose, And the plane's going to have dextrose, a 50% intravenous solution along with a single IV starter kit. So I hope you've brushed up on your peripheral IV skills, or at least you can hope that there's a nurse or a paramedic on board with you. Odds are, you're not going to be the only healthcare professional on the plane. Other contents in your medical kit on the commercial aircraft will include an oropharyngeal airway,
One of those little plastic things that you can put in the mouth to kind of move the tongue aside.
which you can use if you feel comfortable placing it, along with 3 sizes of a bag valve mask so you can ventilate somebody. There's also 500 cc's of normal saline and a short list of medications: aspirin, atropine, and antihistamine, nitroglycerin, intravenous lidocaine, and epinephrine at 1 to 1,000 and 1 to 10,000 dilutions, depending on whether you're going to treat anaphylaxis or cardiac arrest. But even though this list was pretty comprehensive for most emergencies, I was surprised that it lacks some pretty basic supplies.
There isn't, a glucometer in the basic medical emergency kit, and there also isn't, as you say, a pulse ox.
Also, nowadays you might feel that naloxone or Narcan should make the cut, but you won't find that in the kit.
So I think naloxone would be a really useful thing to have. Potentially also benzodiazepines for someone who might be having a seizure, because that's certainly something that could happen on an airplane. A couple of other things that I would kind of think might be helpful, and this is more from my critical care background, is you could consider something like a portable ultrasound. But as I say that, I would also say that overall it's probably best to keep the supplies on a more simplistic side. And I think the reason for that is that even amongst physicians, people have different levels of training and different levels of comfort with medications and diagnostic tools. And you run the risk of actually causing more harm than good.
I totally get what you're saying here, but could you elaborate what you mean by more harm than good?
For instance, if you had a laryngoscope and an endotracheal tube on your emergency medical kit, I think there would be a lot of physicians or medical personnel that would feel obligated to try and establish an airway in an unresponsive patient. And if you didn't have the proper training to do that or the immediate experience of intubating patients, that could actually cause more harm than good. So I think naloxone probably would be a very, very helpful adjunct, and a glucometer and a pulse ox if available. But apart from that, it's probably, best to just go with whatever is there in the simple medical kit.
Yeah, I think that's a really good point, because the flight crew is going to rely on the expertise and experience of the passengers. To have to carry these extra devices around would just be burdensome and could force people into a position that they don't feel comfortable doing, even if they're early in training or not experienced with that type of tool. And it probably also requires some degree of upkeep. It's relatively simple to maintain an up-to-date, medication kit, but to have to investigate an ultrasound and make sure that all the battery life is sufficient and that the windowing is right and that you can do everything well, that just adds increasing amount of burden. It just seems like some of the most useful solutions tend to be the most simple and most elegant, and something like epinephrine and atropine and insulin and dextrose, I think that those are going to be some of the highest yield medications and interventions for some patients.
I think that's right. I think also, you got to go with it in the principle of what would be the most useful for me to have to immediately provide some kind of life-saving measure. And I think things like epinephrine and a defibrillator and dextrose are immediately potentially life-saving. Whereas a lot of other things that we may use in the hospital as part of our efforts to resuscitate an unconscious patient are not absolutely necessary. And I think they could potentially get misused in the setting of someone who wanted to help but didn't necessarily have the right training to do that. Or, as you say, a piece of equipment that needs constant upkeep and is not able to be kept up in that way. The other thing I would say is that the scenario that we're talking about is really very different from the scenario that we're often encountering in the hospital when we see an unresponsive patient in the ER or on the floor. because there we have the instant ability to call many, many people to the bedside to do a whole manner of specialized things. When I'm practicing in the ICU, I have the ability to call a surgeon who can establish a surgical airway.
Probably something you don't want to be doing on an airplane.
I have the ability to call people who can even establish ECMO at a moment's notice.
If you feel like you need to do this on a plane, just land the thing.
But those types of things are definitely not available on the airplane. And so I think just keeping it simple and making sure that you are ticking off the major things that you can potentially reverse in the few minutes that you have. And then asking the flight crew and the captain to potentially reroute the flight if you're not going to be landing soon to a place where definitive treatment can be established.
Let me interrupt here real quick. While you can always call out for help and recommend flight diversion in emergency scenarios, it's going to be up to the captain and the on-call physician from the ground who works with the FAA to decide on whether the plane should be rerouted to land emergently, or if it's safe to continue the flight to its final destination. I want to get back to the point you made earlier about the experience and the comfort level that some emergency medical personnel, physicians, nurses, respiratory therapists, whoever's on board, the kind of experience that they have and the comfort level they have in dealing with an emergency in flight. Can you kind of comment on the type of thought process that you should go through in your mind if there is an emergency that arises, as far as do you intervene, should you intervene, how much can you intervene, are you protected if you do something?
Yeah, I think those are all really good, important points. So actually starting with the last one, which is, are you protected? And, do you face the risk of having legal action brought against you if you potentially don't do everything that someone may think you should have done? There are protections for physicians that are put in this situation. And I think the general rule is that you shouldn't feel as though you're exposing yourself to legal risk by taking an active part in helping a patient that's in need on an airplane. I think is a natural.
Here's a good place for me to jump in and describe the Aviation Medical Assistance Act of 1998, which protects medically trained providers in the event of a medical emergency during flight. Like each state's Good Samaritan laws, each state and the District of Columbia all have passed some version of a Good Samaritan law. The Aviation Medical Assistance Act protects Good Samaritans from liability should they respond to an in-flight medical emergency. To be covered by the AMAA, the provider does not need to be asked for his or her assistance, nor is the provider liable for any harm done to a patient because of a lack of medical equipment in the standard in-flight medical kit. But the AMAA does have some limitations that are worth mentioning, and you should remember them if you ever plan to respond to an emergency. The AMAA does not cover medical providers for non-emergent medical care that's delivered during commercial flights. If somebody develops a nasty rash because you recommended that they take ibuprofen for a headache, I know it sounds crazy, but that one could be on you. Also, providers are not absolved of any gross negligence during their emergent care. So if you had a few drinks before boarding your flight and they've impaired your judgment,
then it's probably not the best thing for you to offer your help and services.
Because you could be held accountable for any adverse outcome, even if you may not have been at fault. Lastly, you're not forced to respond to any medical emergency, nor should you feel obligated to help out when it comes to an issue that's beyond your scope of practice.
The other part of your question was about what actions or things should be done by, I would say, all physicians if they're placed in that situation. And I think everybody who has medical training has the ability to, number one, identify if there's a dangerous condition going on. And I think that's probably the most important thing. And everybody has the ability to really make sure that the flight crew get the sense that something needs to happen quickly. After that, I think the biggest role for a physician in this case is really directing whether or not any kind of resuscitation should happen. And one thing that you brought up earlier is that the flight crew is in service in doing CPR. And so even if you're a physician that may not have been involved in a code in a long time, you can identify that a patient is pulseless and direct resources to get the defibrillator and to have someone start CPR. And so I think that's really the role that someone should have. And if you go into it with that thinking, I don't think anyone is going to make a mistake in terms of what they need to do.
So, knowing all this, let's return again to the patient, to the middle-aged woman who passed out in row 19. Just for the sake of the show, Ram, let's say that she is slowly regaining consciousness but appears uncomfortable and she's diaphoretic. What concerns you the most here?
Well, I think the one that would be the most concerning is that they had an acute myocardial infarction. That could cause you to have syncope, and if afterwards you appear pale and diaphoretic, it would be of big concern to me that a person like this might have had an acute heart attack. The other things that this could be are something just, more simple like vasovagal syncope. So what I would probably do at this point is, now that the patient has regained consciousness, first introduce myself, make sure that they know that I'm a physician, and ask them if I can do a quick exam and try and deliver some care for them. And then try and get them to a place where they can be supine. Because if this is something like a syncopal event, then they should hopefully get better just with lying flat. And then once that...
And obviously, if the patient is now verbal, you can probably get a better history to rule out scary diagnoses that can result in syncope, things like myocardial infarction, pulmonary embolism, a vasovagal event, or even a primary neurologic disorder like a basilar thrombosis or a seizure.
Also knowing whether or not they're on medications like aspirin or some type of systemic anticoagulation would be helpful to know. And then,
are they taking insulin? Are they on an anticonvulsant? And have they missed any doses of their daily meds?
And if you can, the other thing you can do if someone is hypotensive is most of the medical emergency kits in an airplane should also have some equipment to start an intravenous line and give intravenous fluids. And that could be helpful in the patient who has a low blood pressure. A couple of other things that would be going through my mind, just because this is a unique situation on an airplane, is that there might be certain things that are causing the situation that have happened because the patient is at a lower atmospheric pressure than normal.
We're flying at an altitude of 37,000 feet and our airspeed is 400 miles an hour.
Airplane cabins are pressurized to simulate life at around, I think, like 6,000 or 7,000 feet in the air. But at that level, the lowered cabin pressure also reduces the partial pressure of oxygen from your normal ground level partial pressure of 95 millimeters of mercury to 60 millimeters of mercury, which corresponds to a 2 to 3% drop in your SpO2. Luckily, most healthy adults tolerate this very well, with only minor complaints of headache or fatigue or lightheadedness. However, for some patients who have poor oxygenation to begin with, like chronic lung disease or asthma, this might tip them over. Additionally, in longer flights, the dry cabin environment may also increase your chances of dehydration, leading to orthostasis and syncope. And in addition, people who've had recent surgery can have gas expansion in the area around their surgical site, which could cause problems.
What do you mean problems? Like splinting or atelectasis or...
Yeah, so I think all of those, but specifically I think you could get things like local pain, you can get splinting. You can also get a picture that might look something like decompression sickness. And specifically, if you had the patient who went on a scuba dive the day before and didn't heed medical advice and then, went on a plane, they could have the abnormal, release of gas in their bloodstream that can cause decompression sickness. And so they could have all the different sequelae of decompression sickness, which, can include pain, potentially neurologic events, and other things like that.
Yeah, being on a plane is a very unique environmental situation for your body to be put in.
Yeah, I think probably the best thing is before you take a flight, if you have any chronic medical condition, it's never harmful to talk to your doctor about it. But specific conditions that may warrant this are those individuals that have pre-existing significant lung disease like COPD, where they have low oxygen levels at baseline, or if someone is dependent on oxygen at home, I think that warrants a discussion with your doctor about what needs to be done when you fly. I think apart from that,
there are actually a number of conditions which are expressly prohibited by the Aerospace Medical Association and the American Medical Association for any commercial air travel.
In addition to that, I think
some of these are obvious, like a patient who has a low probability of surviving the flight, or if a patient has an extremely contagious illness, like Ebola, or a pregnant woman who's beyond 35 weeks gestation. But other conditions are not as predictable. Patients with a recent GI or thoracic surgery in the last 2 weeks, anybody who has a large pleural effusion, and anemia with a baseline hemoglobin of 8.5 or less. Neurologic diseases that are contraindicated in commercial flights include stroke in the past 2 weeks, or uncontrolled seizures. But how uncontrolled or controlled the seizures are is not explicitly stated by current ASMA or AMA guidelines.
There was one time when I was on a plane flight and someone had a syncopal event. They weren't unconscious for very long, but the flight crew actually asked if there was a doctor available, and I was the lucky person who ended up attending to this patient. And by the time that I got to the patient's seat, she had already regained consciousness, but it did allow me to have a chance to see what's in the medical equipment in the emergency medical kit on the airplane, and there's not much. In this case, what was interesting was that as soon as I got to this person's aid, there was a respiratory therapist who was also on the plane who actually came right behind me and said, listen, I have a pulse oximeter that I carry around with me that you can use, and it came in handy. And I think it's an important principle that just because the thing is not there in the emergency medical kit doesn't necessarily mean that it won't be there on the airplane. Because there are a lot of people that may have diabetes that have glucose monitoring supplies, and you might find a pulse oximeter like I did.
Okay, so to kind of wrap up the case, so the patient you saw in seat 19F, you evaluated her and she was recovering, you laid her supine, you assessed her oxygenation status, somebody had a pulse oximeter eventually, and her blood pressure, heart rate, the rest of her vital signs were normal, somebody brought in a glucometer, so you did have a lot of help from all the remaining passengers and the flight crew to evaluate and manage this patient. You know, you're definitely not alone, and it turns out that she ended up having syncope, and it was just a vasovagal kind of syncope that was probably exacerbated by being in a plane and being in a cabin that was pressurized in a way that just reduced her oxygenation status, and she improved over time. And it turns out that syncope and pre-syncope are the most common medical emergency on a plane during flight. And
yeah, I think that's absolutely right. In the patient that I saw on the plane, it was exactly as you said. She had probably a vasovagal response. She actually gave me the history that she'd had some episodes of lightheadedness for some time before and had made an appointment to see a doctor, but just hadn't seen a doctor yet. After I saw her, I did recommend to her and the flight crew that once she landed, it would be reasonable for her to go to the emergency room just to make sure that there wasn't some kind of acute cardiac arrhythmia or something else that occurred. And the other important thing to note is that there usually is some documentation that you have to fill out, as with anything that we do in medical care nowadays. So there was a sheet that the flight attendant gave me just so that I wrote down what I did and what I thought happened. So even on the plane, you can't get rid of doing your documentation.
it seems like it's inevitable.
Yeah.
Okay, well, thank you, Ram. I appreciate you joining me in the show again this week.
Yeah, thank you, Jim.
Before we wrap up the show, a quick word on medical fitness for commercial air travel. Obviously, in emergency settings, with critical care personnel available, a patient may be transferred between medical centers via air, but commercial flights are contraindicated in certain conditions, like we discussed. Although I can't formally recommend this, as this is just an entertaining audio program, or so I hope, it would be my preference if any patient with a severe neurologic illness, like encephalitis, or a major stroke or intercerebral hemorrhage would avoid flying within the first month of symptoms, just because of the nature of the complications and the limited access to medical resources during flight. But, as usual, this podcast is not intended to provide medical advice. It's only for educational purposes and for entertainment. And with that, I think we're going to call it a day. I hope you learned something about a neurointensivist's approach to the acutely unconscious patient, and maybe a little bit about emergencies during commercial airline flights. The Brainwaves audio podcast is produced out of Philadelphia, Pennsylvania by me, Jim Siegler. Music for this week's episode was courtesy of Andrew Sacco, R. Sonor, Chris Zabriskie, Lee Rosevere, and Fabian Measures. For more information about medical disclaimers for our show, I'll refer you to our blog at brainwaves.me. This podcast is intended for educational purposes only and should not be referenced for routine clinical decision making, even if you're on board an aircraft. You can reference the appropriate experts and their papers in our weekly show notes. If you're interested in submitting a topic for the show, or you just want to say hi, you can reach us at bweditorialboard@gmail.com or follow us on Twitter at brainwavesaudio. I'm Jim Siegler, reporting safely from ground level in Philadelphia, and I'll talk to you next week.
And our airspeed is 400 miles an hour. Couple little facts here. I'm packing a Colt King Cobra. That's a .357 caliber firearm with a black rubber grip and a 6-inch barrel. Also, the co-pilot is carrying a Kimber Custom Defense pistol with all the bells and whistles you'd expect from a custom gun of that kind, with an alloy frame and bevel treatment on the entire gun. And I can put a hole in human bone and flesh the size of the Grand Canyon, which, by the way, is coming up on the left-hand side of the plane. So just sit back and relax and enjoy the rest of the flight.